And I always tell everyone, get your blood pressure done in three positions: laying flat, nobody walks laying flat; sitting up, nobody walks sitting up; and standing up. And your pressure will probably fluctuate. That's how we determine really if you really have hypertension or not. So don't just don't have pills thrown into your mouth and stuff, and no one has really worked you up properly with your blood pressure. I am board certified in emergency medicine, trained at the Cleveland Clinic in general surgery. Been doing cosmetic surgery, general surgery, trauma surgery, you name it, and doctors been doing it. I'm very proud to say today, anyways, that I am a graduate of Michigan State University, College of Human Medicine. MSU, of course, is in the doggone tournament, so we hope them well. Wish them well. The other person that I got to tell you guys, without Cadilla, Dr. Cadilla, we would be, and I'm sure that everyone that has seen her and been a part of these different webinars will admit she is an all star, and we really appreciate her being on today. So I'll be talking about a number of different diseases that we've talked about before, but in a different way. And then I'll let her. She can interject whenever she wants to interject, but she'll introduce her slides at the end, towards the end, okay, of the other presentation. And then, of course, if you guys have any questions, as you already know that, please feel free to ask any questions that you may have. We know typically that in a medical situation, a medical setting, you have your own primary care doc or your specialist, whatever you have. Typically, the time that they have for you as a patient is not very much if you see the doctor at all. You may see the nurse practitioner, you may see the PA for the doc. Not saying they're not good, but for some reason or another, I just like seeing my doc when I want to see my doc, and that's how it is with us. So Dr. Cadilla should be on to discuss not only medical medications as such, and but she'll be talking about other alternative things. She's big into the alternative medical side of things, minerals, vitamins, lifestyle changes, and all the other things. So she'll be talking about that. This guy here, I put him on here just in case he was on. I would have ever think Dr. Gavin is not a part of a chronic disease a webinar, and I'm sure that he'll probably come on eventually. And when he does, I'm sure he'll introduce himself and he'll interject. All right. So today, what we're doing is that we're covering medications or lifestyle. The truth about preventing heart disease. We can do that, guys, but we have to do certain things to get that done. So what we're going to cover today is chronic disease in a capsule. I call it in a capsule. And you guys heard me talk about this infinitum. We do that because the grant calls for that, but we can certainly mix it up a little bit, and that's what we're going to do today. Hypertension, heart attack, strokes, congestive heart failure. We have not talked about that very much, congestive heart failure, but I'm sure some of us know someone that has congestive heart failure and they have issues. At the moment of diagnosis of congestive heart failure, you have less than a 60%, 70% chance of living beyond 5 years from diagnosis. Most people are dead by the time they hit 5 years. So it's something that we want to prevent you from getting. And that's through the things that I'll tell you, as well as, of course, Dr. Cadilla, I will tell you also. We're going to talk about for the first time in a little bit of detail, but not much, but hyperlipidemias and how that really does affect our entire body. Hyperlipidemias, as we say, bring it down front, doc. We're talking about cholesterol levels and we're talking about triglycerides. And cholesterol levels, we need to understand what we're looking at when we look at cholesterol. We're looking at total cholesterol, which is the big number, the total number, right? And we know anything over 200, we consider that to be high, okay? And when we treat those things, it depends on those numbers. But there's two things that you guys should take away from this webinar. But it's so important to understand that when we begin to deal with the hyperlipidemias and we talk about cholesterol, there's two types. There is the good cholesterol and there's the bad cholesterol. If your cholesterol level is 400, but 300 of that is HDL, you got a roto-rooter going on. Everybody know what a roto-rooter is? Something that cleans out, the toilets, whatever you want to call it, cleans out those pipes. That's what HDL does. It cleans out your arteries, guys. So when you hear that big number, if you got a big number, you want to know two things. What is my HDL, high density lipoprotein? What is my LDL, low density lipoprotein? So all elevated cholesterol are not bad. It's just that it seems to turn out that way, that most of what we have going on looks like it's going to be the LDL, low density lipoproteins. And of course, this leads to blockages of the arteries. And I'm going to have one super discussion at the end. It's going to be brief, but it's about things that we don't even talk about, guys, especially in Black men. This thing called an abdominal aortic aneurysm. I'll slow it down. An abdominal aortic aneurysm. This is also caused by, guess what? Plaquing inside of your main artery that takes the blood from your heart all the way down to your intestines to your legs. When that artery ruptures, then I'll show you a slide on that later on, but it's not a pretty sight. So we're going to look at peripheral vascular type disease. And again, like I said before, Dr. Cadilla should be wrapping up all medication side effects and lifestyle changes when I complete covering my part. Like I said before, the webinar is recorded. So that means you guys will get all of these slides. You get the presentation, and there's a QR code. I should say yes, QR code here that's in the bottom right-hand corner of my screen anyways. If you were to scan it now, it'll take you right to our website, and you'll see what's happening with that. All right. So let's talk about hypertension, hypertensive crisis, and emergencies, basically. There are basically what we call two stages of hypertension. And this is something that you guys should know. And some of these things we treat, some of them we just tell you to exercise and watch your salt intake. But stage one is where we have a blood pressure that is consistently ranging between 130 to 139 systolic pressure, that's the top number, to 80 to 89 diastolic pressure, which is the bottom number. I always tell people this. To me, the bottom number, as an ER doc, I'm more concerned about your bottom number. Because your bottom number is going to tell me if you're going to have a stroke, heart attack, and going to tell me if your heart's going to continue to get bigger. Because that's the resistance that your heart is pumping against, right? When the heart pumps blood out, boom, push it out. That's your systolic pressure. It goes up, and it should go up, right? But your diastolic pressure is when the heart is at rest and the vascular compartment is at rest. But those arterioles, which is fine tuners, it has a blood pressure too. That's the bottom pressure. So whenever your heart is, just think of it this way too, guys. Whenever your heart is beating against more resistant, that means something has to get bigger, right? It's heart is a muscle. It's a cardiac muscle. When it gets bigger, guess what happens? There's an increase in blood supply. Now I see guys work out like my son, Dr. Moise, and certainly I'm sure Pastor Jackson and others, they work out, they're all buffed up and stuff, right? If you look at these guys' arms, they have these big veins popping out of their arms. Also, they have an increase in blood supply, not only taking blood to the heart, but bringing blood back to those muscles. Heart is totally different. Heart gets bigger, it does not increase in blood supply. Therefore, when you eat something and you have, let's say, backclogging up of your arteries, you get what we call postprandial, which means you get post-eating heart pain. And these are real things. So that's for stage two. And I'm sorry, stage one. Stage one is basically managed by sometimes medication, oftentimes not. Usually it's going to be a modification of your diet, typically. Then the next stage, you guys, I know there's two stages of blood pressure problems. The second stage would be that of a constant blood pressure, a systolic pressure, top pressure of 140 millimeters of mercury or higher. So remember that number now. The second, if we were in class, and I will tell you guys, write this down. One of these things just write down, because your doctor should know this too. But your stage two hypertension is a sustained systolic pressure. Notice I said sustained. That means what, guys? That means that you go to your doctor's office on different times of the day, morning, afternoon, evening time, and get your blood pressures done. And I always tell everyone, get your blood pressure done in three positions: laying flat, Nobody walks laying flat. Sitting up, nobody walks sitting up, and standing up. And your pressure will probably fluctuate. That's how we determine really if you really have hypertension or not. So don't just don't have pills thrown into your mouth and stuff, and no one has really worked you up properly with your blood pressure. You guys, I want you guys to understand. You just need to ask your doctor's question. Hey, doc, you took my blood pressure one time, and yeah, I came in and I was a little whatever you're doing, you're busy, whatever it was, and now your blood pressure is down or up, whatever that situation might be, right? So you want to make sure that the doctor understands that you know what's supposed to be doing. Now, for stage 2 hypertension, again, for your diastolic pressure, that's the bottom pressure, that number should be consistently over 90. Okay. Now, what that put you in the realm of? It requires medication typically, and it requires some other lifestyle changes, eating certain things, which Dr. Cadilla, I'm sure she'll get into all of that. Then we get into things that I like to talk about, and that's called the hypertensive emergencies and those kind of things. Hypertensive emergencies is when you come in and your blood pressure may run anywhere from, let's say, top pressure. Check this out, guys. Over 180. That's your top pressure. Bottom pressure is over 120. Right? So there's no suggestion, there's no argument about what we're going to do. You see Dr. Reynolds in the ER and you see other board certified ER doc, you're going to most likely be treated with some medication, IV wise, right? So we got to get that blood pressure down. I would say fast, but get it down consistently where you see it coming down to normal. Then you may or may not discharge the patient based on the doctors who are doing an X-ray on you, electrocardiogram on you. And yes, if you're not had an echocardiogram, look at the structure of the heart, that should be done too, because your hypertension leads to all of those kind of issues as well. Hypertensive urgencies, of course, that's something also that we look at. Look at the blood pressure, as a basic understanding, guys, as being like you have a pipe. You're a plumber, you have a pipe, and you know that the water is trickling out through the same size pipe. And if you check the pressure in that pipe, that pressure will be low in that pipe because you have decreased amount of volume, fluid in that pipe, but the pipe's still a pretty nice size. Imagine for a moment, you pump in a lot of water into that same pipe. What's going to happen to the pressure? The walls will be in the beginning knocked down, inundated with pressure going up. Same thing happened with your arteries, the exact same thing. So that's why we use diuretics to decrease the volume in your piping, in your plumbing, in this case, in your blood vessels, right? And we also will dilate those blood vessels with certain medications too. And we'll sometimes slow down the heart, depending on what we're trying to accomplish. So, again, I just talked about the hypertensive emergencies and those kind of crises. African Americans, there's no doubt about it. African Americans, especially African Americans, we have a much higher incidence of mortality following pretty much most of our chronic diseases with our Anglo counterparts, our brothers and sisters Anglo counterparts. 40%. We have an increase in mortality of 40%, guys, across the board with all these different chronic diseases, whether it's going to be heart attacks, whether it's going to be stroke, whether it's going to be diabetes, whether it be a kidney disease. I'm going to for a minute. So when we get these issues, there's some socioeconomic reasons for that. There's some other variables in that. And we'll talk about that probably at a later date. But the understanding is that when we get diagnosed, guys, with hypertension, you want to make sure, because this is the one thing that we can do to save ourselves. No one's going to save us but ourselves. Sometimes your doctor, he's so busy, whatever it is, they're not going to help save you either. You have to educate yourself. I tell people all the time, and we all know the Bible says, for lack of knowledge, my people perish. So I want to make sure that we understand that we get this right. And we want to continue to do what we're doing. But you need to understand that these things are important, especially in our community. Okay. So heart attacks, we already know that. Coronary artery disease is the main reason for that. But I want to talk about coronary artery spasms. Does anybody know what that is? What that actually means? Coronary artery spasms. Well, it means that you don't have any blockage of your blood vessels. Certainly, when Len Bias died on the floor as he was, I think he was a Boston Celtic, where he could, I think, even shoot a hoop in a game. He fell dead on the actual court. We had Hamlin, who I think he played for the Buffalo Bills. He started on national TV. It was a shock to most people, but for me, it's just what I see. Didn't have any coronary artery disease, had an arrhythmia, right? Bronny James, he did not have coronary artery disease as we know it. He had an arrhythmia, right? So there's many different things that can cause that arrhythmias, but certainly spasms. One of the main culprits when I'm in the ED and have a young person come in, black or white, it doesn't matter because we all do the same things. Be honest about it. The first thing I want to rule out is cocaine poisoning. Okay, cocaine is a very potent vasoconstrictor. Stoom, makes the blood vessels clamp down. When blood vessels get smaller and clamp down, guys, what happens? It means that your blood pressure goes up, but it also puts your coronary arteries into spasms. There's a couple other things I put in there too for a reason, because it's real. Smoking. Now, I know a few of us smoke a stogie from time to time. I'm not really talking about that kind of smoke. You don't inhale that stuff. If you do, you're probably going to die quickly. Okay. But smoking cigarettes is definitely bad. The other thing, guys, and we'll be talking about this on our next go round, stress. We'll be talking about how it is that um, mental health plays a big role in all of our chronic diseases. Believe it, in all our chronic diseases. So I have a surprise list of people for that, including some pastors and psychiatrists and so on and so forth. This should be fun. Other thing is arrhythmias without there being a blockage of your heart or anything, as I mentioned earlier, can cause you to have a heart attack. Too fast or too slow. I don't know if you ever have seen a patient that have what we call hyperthyroidism, and they have these what we call them bulging eyes. Uh, those patients tend to sometimes go into what we call a thyroid storm. And the nurses know what I'm talking about because I'm sure they've seen people like that. When you see it, it's something that you just deal with it. We give them medication to get them down, and they do okay. However, if they don't get treated fairly quickly, because the heart is beating so fast, we're talking about a sinus beat. That means coming from the right node, the right thing that should be coming from, at about 180, 200 beats a minute or more. That means the heart doesn't have what time? Doesn't have time to fill up. So if the heart cannot fill up, heart cannot get the blood that's been oxygenated out to the brain, out to the other vital organs. And always remember this about, if nothing else you remember today, remember this. Oxygen deprivation is the thing that kills all of us. At the end of the day, I don't care what disease process you have, but think about it for a minute. If you're not getting the oxygen to your brain, what happens to the brain dies, right? If you're not getting oxygen to the heart, you have heart attacks. The heart dies, it stops beating. You're not getting oxygen to your liver, it dies too. Every tissues in our diabetic patients, they lose limbs because they're not getting oxygenated blood going to their limbs. So always remember this. If it's something that's going to interfere with your oxygen, it can cause systemic problems throughout your entire body. Good to remember that part of it. VTAC, that's something it's maybe a little technical for you, but VTAC means that rhythm is coming from your ventricles, which is not from the upper chamber of the heart. And it's beating too fast, all of a sudden now you're going to pass out, most likely. If it's not treated, you'll most likely go into what we call a terminal rhythm called VFib. And that's where you have those AEDs around, guys. I see most of the churches I've gone to, they have AEDs. We're going to put on a webinar just on how to use AED with a couple of paramedics, because I want you to know how to use what's available to you. It's kind of sad to have a tool available, don't know how to use it. I have an AED in my house here, a little older fella, you know what I mean? But anybody can have a heart attack, I guess. But you don't have to have a coronary artery disease, as I just mentioned, to have a heart attack. So that part is important. Moving on here. Non-cardiac causes, we talked about that before in terms of diagnosis, treatment, prevention. Diagnosis for heart problems to me, is relatively straightforward. If you're just going to have just a workup for hypertension or for heart problems, you're going to start most likely with a chest X-ray. Gives them some idea in terms of the size of the heart. You're going to have electrocardiogram done. Tells about the electricity of the heart. Remember, we talked about that thing called arrhythmias here, right? Well, we're not talking about that now. But we're talking about something a little different than that. Then we're also talking about, I'm going to say it, um, as you go off on these different treatments and the diagnosis of these different things, then sometimes, just sometimes, it requires a surgical intervention. Some heart attacks mean that you have what we call an ST segment elevation. My nurses know that's called a STEMI. That's a real heart attack, right? Those patients go directly from the ambulance or the waiting room. They'll drop by and see me briefly in the ED. We'll shave their groin down. We'll get them. Their calf lab has already been notified. Every hospital that has a calf care or heart care, they have a calf lab. Those doctors, the cardiologists, are on call 24/7 to take that. They have to be in the hospital, guys, within 10 to 15 minutes of the call. Time, remember, for the heart is what? Muscle. The longer you wait with a heart attack, the less likely you are going to be able to survive that heart attack, right? So that's that part of that. And then we have other surgical reasons for doing this thing too. Valvular problem, which, it's echocardiogram. That's the other thing I wanted to mention. I know that we all get chest x-rays, we get EKGs, really it should be called ECG, electrocardiogram, but we don't get echoes. So listen to me now. And we got a lot of people on, which I'm so happy about, thrilled about the numbers. But listen to me carefully. It's so important to get an echocardiogram. If you're a person of color, especially an African American male, by the time you're 45 years old, you should have your first echo done. The echo tells about the structure of the heart and how that works. And I'll let Dr. Cadilla get into the medication that we give, things that you can do to improve your outcome when it comes down to that. But it's so important to make sure that your valves are functioning well. That is, listen to your heart. When a doctor puts a stethoscope, that one, when a doctor puts a stethoscope on your chest, he's listening for sounds. And if you have an abnormal heart sound, boom, psh, boom, psh, boom, psh, boom, psh. I'm not putting on no rhythm and blues here, you know what I mean, guys? I'm talking about what we hear when you have a systolic ejection murmur. Psh, boom, psh, boom, psh. That is something that we want to make sure, guys, that we understand what that is and get it into treatment. But if your cardiologist has not done an echocardiogram and you're 50 years old, then you got to ask the reason why. Be your own advocate. All right. I'm an advocate for you too. All my doctors here are advocates. All my people, nurses are advocates for you. But we want to make sure that you ask questions too. And I can tell people, and I've talked to a lot of people now, they know they have my number 24/7. I'm 24/7 docs. Like I'm in the ER again, right? I'm able to answer most of your questions. So we'll move on from there. In terms of stroke, we all know about strokes. We've had it before in the past. There's been a number of different times that we talked about it. What's important to know about a stroke can be two types of strokes we have. Fortunately, the most common stroke we have is called ischemic stroke. That is something that causes something to block, whether it's going to be a plaque, whether it's going to be a little clot, whatever it is. It causes there to be a decrease in blood flow to a particular side of the brain. When that happens, you have those stroke type symptoms, right? And I guess we'll go over that later on, but I think we talked about that ad nauseum now regarding signs and symptoms of a stroke: slurred speech, blurry vision, dizziness. Yeah, your balance is off. You cannot think of something that you want to say. It's there, but you just can't bring out aphasia, dysphagia. All these different things are there. Visual type problems. Okay, swallowing problems. These are all signs of a stroke. Remember this also, guys. If you have symptoms on the right side, that is a weak arm, a weak leg, drooping typically of the same side of the stroke, then that stroke is on the opposite side, right? Understand that too. So it's a crossover system, right? So if you have symptoms on the right side, stroke is on the left side of the brain, right? So that's how it works out. And then Dr. Cadilla should talk about different medications here shortly regarding that part of it. we're almost done here, guys. Classification of congestive heart failure. I'm not going into any real details. I just go over a few things with you about it. And it's classified as class 1, class 2, class 3, and class 4, which is and the diagnostic tools that are used basically are laboratory studies, looking at your beta natriuretic peptides, your BNPs, although that can be kind of like iffy, I guess, because there's a lot of other things that can make your BNP go up. That's a blood study. But the thing that I'm most impressed by with this particular tool is an echocardiogram. It tells you about your ejection fraction, how much blood your heart pumping out at any point in time of the cardiac cycle. That means, boom. When I refer to the pump, I'm not referring to the right side of the heart. Right side of the heart is important, but the most important part of the heart is the left side of the heart, the left atrium and the left ventricle, and it pushes the blood through. So I want you guys just be, a little knowledge on that part of it. And then, of course, there's different treatments. I'll let Dr. Cadilla go over those types of treatments, but there are many of them. And there's right
Doc,
side.
as you approach transition, just want to bring to your attention Mrs. Eleanor Hickman, who's also a first timer, was diagnosed with postpartum cardiomyopathy in
Cardiomyopathy.
1998.
Right, right.
Well, did you want to say anything to the doctor, Mrs. Hickman, Sister Hickman?
Uh, I didn't know I had that. I had my son in 1997, November. I was diagnosed January in 1998. I was sent to Jackson Memorial Hospital for a heart transplant. Thank God I didn't get one. But in 2014, I did have a mitral valve repair. That was October 2014. The heart was still functioning at 25%. And I did wind up getting a defibrillator in February 2015. So right now the heart is functioning at 42%.
Yeah. I'm saying yeah because I like hearing that part of it. Cardiomyopathy post how can I say what either it's going to be shall we say post having a baby, postpartum. It's going to be intrapartum. It doesn't really matter. But when you develop that, it can come on very late on, right? You had it coming on from probably day one, but they gradually caught up with that. At least you had symptoms enough where your heart ejection fraction, I love what you just said. Your heart ejection fraction, I think you said was a 20, 25. What was that?
25.
25, right? Yeah. The normal ejection fraction, by the way, guys, should be anywhere between 55 and 60 and above. Old Dr. Reynolds ejection fraction, I get it, my check pretty much every year. It's like at 72. All right. So everything is good. But to know that you have gone from an ejection fraction of 25 up to 40 now, that proves a point that Dr. Talked about, Dr. Gavin talked about, I think a couple of times ago, that these things can be reversed, right? Medication, watching your salt intake, a lot of, doing cardiac rehab, those kind of things, those are all important. And I'm glad you're not getting heart transplant too, because that would have been, I don't know, they're good when you just really have to have one. I guess you must have been on the list that you really had to have one, but God is always on the throne, sits high and he looks low.
Amen.
So that was not your time, sister, to have a new heart put in. Leave the heart for somebody else to get. Okay, so all righty. So moving along here, treatment and prevention of heart failure. Now, what they did have also available to you, sister, was it's called a left ventricular assist device, right? LVAD, we call it. And those things are mechanical. They put it inside of your chest into the major vessel, the left side of the heart, which is the pump. And it's a machine. And I have fun with medical students and some doctors too. When I ask them, did you hear any murmurs? How was the heartbeat? Okay. Well, it's a normal systolic pressure, and I said, no gallops, no murmurs, da 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 da. I said, let's go back and listen to that patient again. Zzz, That's all they hear. So what do you think that is? What do you think that guy has around his waistline? It's a pack. He has an LVAD. You know what happens at doc typically? They're out of the program. They lied to me. They lied to themselves. They never listened to the patient's heart. Okay, so it's really important again to be your own. How can I best say it? Be your own advocate, but ask questions. Right, but heart failure is serious, and I'm so glad that sister brought that up because this is something we don't talk enough about. I'm glad we spent a little bit more time on doing it. I'm moving right along here. Now, hyperlipidemia, that's going to be primarily handled by Dr. Cadilla, but keep in mind again, it causes all kinds of issues, and that's when the levels are high. And I already talked to you about that early on, and that part of it is important. And I said we must talk about aortic aneurysm, and that came up too quickly, but it's serious, I guess. It's significant, and what happens when it ruptures? You pray. You pray to the Lord upstairs. But guess what? You're ready to go meet Him. When an aortic aneurysm, which is the big vessel, the big blood vessel, the main vessel that carries blood throughout your body, coming it's down in your abdominal area, when that ruptures, one is significant pain. Then you usually pass out. If you get to the ER, and I've done this a couple of times where I just open you up, we cross clamp above and below the arteries to try to get the blood to stop. The problem is that they can't get to the ER quick enough. So when they come in, their abdomen is bloated, they're big, because guess what? It's full of blood. Those patients, when they rupture, it's a bad situation. So the key takeaway from this, guys and ladies, when you get your examination done, let's say when you're in your 50s or so, usually have it in your 50s and 60s, make sure that your doctor listens to your abdomen right around your belly button. And what they should do, they will press a stethoscope down. They're not trying to hurt you, but they're trying to listen what is called an abnormal sound, turbulence of sound, a flow. Remember now, those arteries get clogged up just like all the other small arteries do. The big ones do too, with plaques, and they can dissect, they can split off. That causes typically severe abdominal pain. Sometimes there may even be a little blood in the urine, microscopic type hematuria, right? So those things can happen. But that is not a red herring. It happens more times than not. And guess when we make our diagnosis? Guess when we make diagnosis, guy? At autopsy. So I'll conclude with my section. I hope that you guys learned something from this. And again, everything is recorded. And Dr. Cadilla, it's all yours.
All righty. So let's start talking about common high blood pressure medications that you might see or might be on. So I just included here just a number of medications that are commonly used for high blood pressure. Some of them are used first line, and the rest of them are used second and third line. If you have specific conditions that comorbidities that in addition to high blood pressure, then your doctor might choose some of these second line agents first for you based on specific conditions. But ideally, if you just were diagnosed with high blood pressure, your doctor will probably put you on either of these first line agents, which is either an ACE or an ARB, which is an angiotensin inhibitor or a blocker. Examples of those are all the ones that end in pril or artan. So losartan, valsartan, olmesartan, or lisinopril, enalapril, captopril. Your doctor can choose also to do a thiazide diuretic. So that is a specific type of diuretic. Those are two in that class. It's chlorthalidone or hydrochlorothiazide. I prefer, and it is preferred for you to use chlorthalidone over hydrochlorothiazide because chlorthalidone is more powerful at lowering blood pressure compared to hydrochlorothiazide. And also, chlorthalidone has shown to protect you from having major cardiovascular events in addition to lowering the high blood pressure. So it protects you from having heart attack and stroke, in addition to lowering that blood pressure, compared to the hydrochlorothiazide, which doesn't have that additional data proven. Yes.
Let me make a comment, if you don't mind,
Go ahead.
Dr. Dillon.
Mhm.
I've done a lot of extensive research on that, and so has Dr. Gavin as well. The first line treatment for Black folks, I'm gonna just bring it down Front Street. I've said it a number of times now.
Yes.
Is either thiazide
Calcium
diuretic
channel.
by itself, typically it doesn't necessarily work by itself, but the calcium channel blockers.
Yes.
The data is very clear on that. It's been studied across many different universities and major hospitals such as Cleveland Clinic, Mayo Clinic, Lay Clinic, and others. Amlodipine is the first drug of choice for Black folk that have hypertension. That is a calcium channel blocker.
Mhm.
In terms of the thiazide diuretic, I agree with Doc on that. Hydrochlorothalidone, which I take that along with my beta blocker, which I should be off of that a long time ago, and I won't get into that
Mm.
part of it, but it works for me, but I should be off of that. It's atenolol. It's a tenoritic, which means that it has atenolol as well as hydrochlorothalidone. Hydrochlorothiazide. Let's say that you are mildly hypertensive, and your doctor feels that wants to start you off on ACTZ, which is hydrochlorothiazide. I would not be upset about that. What I would be upset about is lisinopril, because lisinopril has been studied extensively in Black folk, and we tend to get delayed reactions, by the way, guys, to lisinopril. I recall a patient that came to the emergency department. She had been on lisinopril for 5 years, never had a problem. All of a sudden, takes lisinopril. She comes to the emergency department, but she said that she couldn't breathe very well. So it's the nurses they put out in a waiting room. Then the patient gets pushed in like within a matter of 15 minutes. One of the other doctors was going to put on a bag valve mask. No, 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 no. Let me take a look at this lady. Her trachea was about her. How can I say it? Her oral pharynx, her posterior pharynx. The we call it the vocal cords are so swollen. I had to use, and nurses know what this is. Doctors know what this is too. I had to use a 4.5 millimeter ET tube to intubate the patient because it's about ready to close off. So I am totally against, unless they can give me some real good reasons why a patient of color would be on lisinopril. Losartan, I think it's a great medication. I saw someone asked questions about Losartan. I think that's a great medication. I'll remain quiet as best I can.
Yes. So the reason why there is like a delayed effect and then increased risk of some of the side effects with the ACE and the ARBs in African American is because African Americans have the less activity of angiotensin in the kidneys, and so they don't respond as well as any other population. However, if you have chronic kidney disease, these medications have been proven to protect your kidneys long term, if they just add it at a low dose, regardless of the population. Something that is important to note, though, I don't want to get into politics or anything, but the reason why we know that these medications can work in another population versus another is because right now, ethically, it is required by national organizations. Some of them are governmental, like the FDA, NIH. They require that research includes a good amount of specific populations to ensure that these medications are working appropriately throughout different types of population, ethnicities, with different conditions, severity of those conditions, etc. Because those are a lot of factors that can impact on the effectiveness and safety of these medications. Um, and unfortunately, that can be targeted as something as diversity and exclusion or DEI or whatever. And they have been removing that from the requirements of clinical trials, et cetera, most recently with the current administration. So, kind of if you see that in the news, et cetera, find out a little bit more and, reach out to your state senators, people that you know, and make sure we continue to fight for this, because otherwise we're not going to know, if we're not requiring and holding accountable these medical researchers to ensure that they have an appropriate representation of these populations in the clinical trials. And that's my take on there. But anyway, another thing is, why do African Americans respond better to thiazide diuretics than the general population, right? Why are these preferred? They are preferred in the African American population as a first line therapy, in addition to, or as either the thiazide or the calcium channel blockers, but the thiazide specifically, because it has shown that African Americans can respond better to thiazide diuretics than the regular population. Why? Because the type of high blood pressure that African Americans have is more related to fluid and salt intake and salt retention. So it has been proven that African Americans are more prone to and sensitive to salt intake on their diet and retention or elimination of fluid in their body. And so the diuretics have proven to be very powerful blood pressure medications for this population. Again, we would have known that because it is included in the research and we've seen it in large trials. So there's extensive evidence, as Dr. Reynolds mentioned. All right, so second and third line agents, beta blockers, which Dr. Reynolds talked about. There's a lot of different beta blockers. I prefer to use carvedilol to manage high blood pressure compared to the other agents because carvedilol is not that specific to the heart. It also can go into the arteries and help with the manage the blood pressure too. So if your doctor starts you on metoprolol and you're not responding a lot to the blood pressure, you might see a slighter, more aggressive blood pressure reduction with the carvedilol compared to the metoprolol because the carvedilol can go into the arteries and exert that effect that you don't see with the metoprolol. And then the other agents are like spironolactone. That one's another one that's very commonly used, especially if you have what we call treatment resistant hypertension. And then loop diuretics and can be used, but loop diuretics are pretty hard on the stomach, on the kidneys, so we don't use them like, this is probably like a third or fourth line after we've tried carvedilol and spironolactone. We might put the loop diuretics, and then clonidine, hydralazine, doxazosin are other agents that can be used. I believe that there's additional evidence that if you have like heart failure and you're on the African American ethnicity, they might want to use hydralazine um, on you because it has proven to be very effective again at lowering blood pressure in that specific population. Um, and
Is
yes,
that because we're actually making the vessel larger, dilating those vessels? The reason why hydralazine is a very good medication to use, or is something else going on?
I'm sorry, I didn't catch your question, Dr.
The question was, you
Reynolds.
mentioned hydralazine, right? And I know we do that a lot in pregnant ladies when they're having some real big issues um, the,
Mm.
with hypertension, right? But my question was, I know what the answer is. I'm asking questions so that other people can get something from what you're saying, just not which I think is important. Hydralazine, is that a vasodilator? I mean, how does that work?
So hydralazine has an effect on, yeah, base opening those arteries up and dilating, but and so it can have some of the side effects that I was gonna actually talk about, and I didn't include here because I didn't have enough space, but it can have some of those side effects that I was gonna mention of like these medications can be so effective that it can reduce your blood pressure too much too. So it can cause the hypotension too. So very low blood pressure. But Dr. Reno, I don't know if I got into the answer that you were looking for. If you wanted to add,
Right,
of course, biosine.
that's certainly it. You looks like you're talking about hypokalemia also, which is important for those loop diuretics.
Yes. Yes. So I kept the same format of these medications so that you know that based on the medication class, these are the side effects. So going into the angiotensin blockers and inhibitors, they go straight into the kidneys to help regulate the blood pressure, and it has been proven to increase your potassium intake, so increase your potassium retention. So you can have high potassium on that medication. You can also get swelling of the lips and the tongue, and that can happen throughout any time on the treatment. So, like, you can be on the medication for a while, not have the side effect, and then all of a sudden it appears. Thiazide diuretics can do the opposite. So, it can cause low potassium and also low sodium. And another thing is it can cause a gout flare because it can cause uric acid levels to increase significantly. So we actually avoid these agents in people that have gout. Calcium channel blockers can cause the swollen hands and the feet that Dr. Reynolds was mentioning. And the other thing was the flushing and the dizziness. In terms of the second line agents, the side effects are going to be very similar with all the beta blockers. They can cause the hypotension, but specifically, they can also cause really low pulse. If you have diabetes and you're on insulin, just know that this medication can mask low blood sugar symptoms too. So you may not be able to detect that you have a low blood sugar until you're really low. Um, and if you have asthma, these beta blockers can worsen your asthma symptoms. And one very rare side effect is low sexual desire, so low libido. That can happen with beta blockers. And if it does, definitely report it to your doctor so we can switch it off to a different agent because not all the agents cause low libido.
Now, we don't want to just gloss over that, doc, because I know a lot of my fellows is on. They listen to what you're
Hmm.
saying. I know what they're probably saying. Oh, okay, well, yeah. Well, it's a real problem, fellas. So we know it's a problem. So what you got to do, you need to talk to your doc about maybe looking at other medications that's not going to cause a problem for you. And then there's other things that we can do to help you out with that too. But that's another subject for another day. All right.
Yes. So, whoops, I don't know what happened here. But so the MRAs, these are mineral corticoid receptor antagonists. These can cause also high levels of potassium. So making sure that you're staying up to date with your the labs that your doctor is ordering can definitely help prevent that side effect. And then the loop diuretics, again, they can cause low potassiums and also a gout flare because they cause high levels of uric acid, which is the accumulation of uric acid is what causes those crystals to accumulate in your extremities and cause those gout flares. All right, and then the hydralazine, which is the one that I didn't include here, but was after the loop diuretics. This agent, of course, causes that relaxation of the smooth muscles. So by relaxing it, it vasodilates, and so that's the mechanism of action of that. Of course, it can cause like fatigue and extreme, the other extreme, which is low blood pressure. I don't know why I have that.
She's talking about the smooth muscles of the blood vessel,
Here we go.
the
Perfect.
arteries. Okay, arteries have muscles in it. Veins do
Mhm.
not. All right.
Mhm.
Okay.
All right, so heart attack medications. So these medications, I don't know why my slides don't want to progress. Okay, here we go. So when you have a heart attack, right, there's a lot of medications they're going to load you up on in the hospital, but then once you get discharged, there's what we call the ABCs. There's other terms that we use for the ABCs, but in this for the purpose of this presentation, I made it extra simple with the ABCs. So we have anti-blood clots. So those are going to be medications that are going to prevent you from having another blood clot, help dissolve the blood clot, but that's more in the inpatient setting. And of course, because they're going to be anti-blood clots, they can increase your risk of bleeding. Those are some of the side effects. I think I progressed through the slides too much. Okay, here we go. So the anti-blood clots would be like aspirin and clopidogrel. And then a lot of the heart attack is usually caused either by high blood pressure or high cholesterol or a combination of both, right? So they're definitely going to try to send you home with your blood pressure controlled. So you're going to have blood pressure medications as well as they might need to put you on something to control your heart rate too. And the common medications that are used in these we already have talked about it, but the ones that end in sartan, the lisinopril, but they might also use beta blockers, like metoprolol or all the other ones that end in lol.
Let me make
Another
a, if
very
you don't mind,
crucial.
you don't mind,
Uh,
yeah, let me make a little comment about aspirin because we need to talk about that for a brief moment. Aspirin should only be taken. This has been, I guess, for the last 15 years about the American Heart Association, as well as the people that monitors and take care of the brain, the stroke people, about the use of aspirin, 81 milligrams, which is they call it baby aspirin, right? It
mhm.
is no longer recommended to be taken, listen to me very closely. You can look it up, Google what you want to do with it, but it's no longer recommended to take aspirin because your doctor said, well, we want to prevent you from having a heart attack. If you've had a heart attack or a stroke, yes, you should be on some form of an aspirin, right? But if you have not had a heart attack or a stroke, guys, do not, I repeat, do not take an aspirin. There's so many more people that die from gastrointestinal bleeding from taking aspirins than aspirin being a benefit for them. So I just want to throw that out there.
So in terms of the cholesterol control, which is another very crucial pillar for the ABCs after you have a heart attack, you'll be sent home with a statin to prevent you from having a subsequent heart attack or stroke. And then the statin might not be enough to control your cholesterol, so they might send you home with non-statin therapies too, like ezetimibe, Cedia, Repatha, and other agents that are used to control other types of like cholesterols like triglycerides, so the Vascepa, the fenofibrate, but that's usually started outside of the hospital. But it is definitely crucial to be on something for lowering the cholesterol. Ideally, we want to keep you on a statin because that one has extensive evidence proving to protect you from having a heart attack or a stroke, and it also has some anti-inflammatory effects on that artery that you don't get with other therapies that are not statins.
Well,
But of course, with that
Dr.
comes
Cadilla,
side effects. Yeah.
yep, so sorry. So you're hitting, you're knocking on my door here.
Yeah.
I have two friends that look like a picture of health, and we discovered after the fact, after massive heart attacks, they died of the cholesterol issue.
Mm-hmm.
And then myself, I don't know if I've even shared this with Dr. Reynolds. I don't have any symptoms of diabetes or hypertension, but I was diagnosed with high cholesterol, and I did receive a little pill. I take a half day, and it's so alarming because when I read that bottle, it says to prevent, as you're sharing, strokes and heart attacks. So I
Mm-hmm.
just kind of want to throw that in. I guess the question here, you can have high cholesterol and not have some of the other medical issues like diabetes and hypertension. Is that a safe assumption?
Oh yeah.
Mm-hmm.
You
So
can.
So I just want to be mindful of the time. So I'll go quickly through these slides, but if you have any questions, please feel free to send me the questions in the chat and I'll try to get them before we're done with the presentation. But yes, as Dr. Reynolds mentioned, there's increased risk of bleeding and bruising with these medications. If you notice that you have dark tarry stool looking like coffee ground or your blood in the urine, those are things definitely to like go to the ED immediately. The bruising, of course, if it gets like bigger, larger, painful, that's something to report to the doctor, but not much as like going to the ED because you have blood on the urine or on the stool, because that could be a major gastrointestinal bleeding that can happen with and commonly with these agents.
Come to that.
Aspirin is no longer recommended for primary prevention in the majority of the population, but your cardiologist might still use it in you if you're someone that is like a very, very high risk. So there is still a criteria for primary prevention, which means using it in people that haven't had a heart attack or stroke to prevent you from having the first one. But it is with very specific criteria. It's not just like, oh, just take a daily aspirin like it was recommended for years and years and years.
Can I say something real quick too?
Yeah.
The reason why, guys, that it's important when you think you're having a heart attack to take an aspirin, because imagine for a minute the artery has a plaque in it, right? The plaque breaks off. It goes down to a more distal, smaller artery, causes what we call a small infarct. That means that the heart, that part of the heart, will not be getting blood. Period. Okay. So, but what happens is that where the clot broke off, where the plaque broke off, guess what God has made happen? He was so great in designing our hearts that guess what? The platelets go and seal that area off. Unfortunately, amen, the platelets keep on coming. And they just keep on coming. So you go from having a mild heart attack to a massive heart attack. So one of the first treatments that we give for patients who have chest pain is not oxygen first, it's not nitro first, it's an aspirin sublingually first. So I don't want you guys to misunderstand me now. When it comes down to chest pain, I would not recommend taking an aspirin if you may have a bleed going on in your head also, a stroke. But for a heart attack, 100%. Right? If you're bleeding, we want to make sure that the bleeding stops. We don't want to stop bleeding from, from clotting. We want that blood to stop. I'm done. Go ahead. This is always so good. Go ahead.
All right. So, um, in terms of the side effects that can happen with the cholesterol medications, with the statins, you can see some unexplained muscle weakness. That's called muscle myalgias. That happens, very commonly. I've seen a patients describe as like, I feel like I went to the gym, and you didn't, and you have like extensive weakness on the in your muscles. That can happen just because you had that side effect with one statin doesn't mean that you're going to have that same side effect with another statin. And the reason why this side effect happens is if your doctor chooses an agent that a statin that crosses the muscle barriers more, like it penetrates the muscles more, then you can have this side effect. But there are some statins that don't cross the muscle barriers that much, and so it doesn't have that risk of the side effect of the muscle myalgias significantly, right? So that's why I say if you have that muscle myalgia with one of the statin, doesn't mean that you have failed all the medication class and you're gonna have this side effect with all the statins. And again, I would give it a try on another agent that it maybe doesn't have that lipophilicity, meaning attraction to the muscle and penetrating the muscle. I would still give a try to a second agent, even if you had that uncomfortable side effect with another previous agent, just because of the extensive benefits that the statin has. I would give it a try for sure. Um,
There's someone asked a
so
question
the
in the
other,
chat. I'm sorry to
uh
cut you in. There's someone asked a question in the chat, and it was about Pastor Philpott regarding if one statin is better than the other statin.
Yes, rosuvastatin and atorvastatin are notorious for being the agents that are more tolerable. So if you had to pick in between any other statins, the atorvastatin and rosuvastatin do not like the muscle, do not penetrate the muscle as much as the other statins would. Simvastatin is a magnet to the muscle, so it has a higher risk of having that side effect of muscle myalgia. Also, simvastatin is super super old. I don't know why they still use it. They still have my mom on it, and I've been trying to get her out of it, and I don't know why the doctor doesn't want to. But simvastatin also interacts with a very common medication used in the African American population, which is amlodipine. Simvastatin levels in the blood increase with use of amlodipine. So if you take amlodipine and you take simvastatin, the simvastatin levels go up, and so you have like double the amount of that medication in your body and you don't eliminate it on time, which increases even more the risk of having that muscle myalgia. And it literally happened to my mom within like a day of taking it. She was like, I felt like I was hit by a truck. That's how severe that drug interaction is. So kind of, ensuring that the doctor is making those decisions with you, and using the appropriate agents that don't interact with other agents that you might have a cardiologist prescribing this and an endocrinologist prescribing these. Are they both talking to each other? Are they aware of the medications that you're taking, right? So making sure you always have an updated medication list and that your doctors are all aware so that they can make the best clinical decisions when they have you at that appointment.
That's why,
So,
guys, that's why,
mhm,
guys, keep cutting you off, doctor. That's why, guys, it's so important for the doctor to be able to communicate with the pharmacist. And if the
mhm,
doctor does not, guess what the pharmacist do anyways? They have responsibility also to let the patient know if we got an interaction here. But we're
yes.
gonna have we're gonna have a special doc for you, and I wrote it down already. Ask Dr. Cadilla. That should be one of the webinars. I'm serious. This is good stuff.
Yes.
What is
So,
it?
someone's question, you can take the statins at any time throughout the day. It doesn't have to be at night. However, the really old statins, the one that were first out in the market, simvastatin, of course, is like a perfect example. That one has a very short half life, meaning it stays in the body for a very short time. It doesn't stay in your body the whole day. So, because of that, then you do have to take simvastatin at night. You can't take it at any point in the day. Why do you have to take simvastatin at night? Because it is very short duration. It stays in your body for a very short period, and it's an anti-cholesterol med. It's used to lower your cholesterol, right? And you produce more cholesterol at night. And so you need the statin to work at lowering that cholesterol that you're producing at night. So that's why the simvastatin, because it's short duration, you need to take it at the perfect time, that when your body needs it, which is at night. And but that not all these statins you have to take at night. Only the old ones that shouldn't be used that much. But atorvastatin and rosuvastatin are newer. They have a longer half life, meaning they stay in your body for the whole day, and so you can take them at any point during the day. However, blood pressure medications,
Dr.
if
Della,
you're taking,
can you look at mine? I'm showing you something on the screen. This is
oh,
mine.
what did it say?
Is that what you're talking about? That
Uh,
you're taking?
SOCOR
No,
is, I can't read it. It's blurry.
it's ATORBASTIN.
Atorvastatin, you can take it at any point during the day. Like, doesn't matter if it's in the morning or at night.
So this is a good one.
Yes, that's a good one. That's a good one, and it's also it comes in high intensity and moderate intensity strengths. And
That's
people with
20
diabetes,
milligrams.
people with diabetes have a chronic inflammatory process going on because they have chronic high levels of sugar in their blood. And it's already known that that can happen. So, people with diabetes, doesn't matter if they have normal cholesterol or really high cholesterol, they are still recommended to take a statin every day that is of moderate intensity or high intensity, not just a really baby dose, low dose. No, a strong, moderate, or high intensity statin is indicated for everyone that has diabetes, regardless if they have normal cholesterol or not, because we already know that they have an underlying risk factor um, in having a heart attack or a stroke, regardless of their cholesterol, because of that chronic inflammatory
Doc, you were
issue.
answering the blood pressure question, and I think we cut you
Yes,
off.
answering the question of the blood pressure medications. If you're taking multiple blood pressure medications, I recommend that you space them out. Don't take them all at once, because otherwise then your blood pressure is going to tank. And that happens very commonly. I talk to my patients and they're taking all their meds in the morning. No, if you're taking 2 to 3, 4 blood pressure medications, which is very common, right? Because it's really hard to control blood pressure, and you might need, very commonly, you're going to need 2 to 3 agents to control your blood pressure. I recommend that you space them out. So, if you're taking 3 to 4 agents, definitely take maybe 2 in the morning and 2 at night. Now, if you're just taking a combo pill, usually the combo pills have like an extended release formulation where it's going to release slowly throughout the day, so you don't have to worry about that. Um, and if you are experiencing side effects of like fatigue and like dizziness with your blood pressure medications, then it is preferred that you take it at night so that you are sleeping it off, basically the side effect of the medication, compared to if you take it in the morning and then you got to go to work and start driving, etc. So, congestive heart failure medications. This one's going to be pretty brief. There are 4 key medication classes that should be used in people with heart failure, because they have proven to reduce the risk of dying of heart failure or being hospitalized because of heart failure. And those are the 4 classes is right here. Now, it is important for you to know that there are 2 types of heart failure. I'm not going to go into the details, but there is a rare type of heart failure that is called diastolic heart failure. It's also known as HFpEF, or heart failure with preserved ejection fraction. And unfortunately, for that type of heart failure, there's only one medication that has very strong evidence to reduce the risk of death and hospitalization, and that is Farxiga. So if you have heart failure, doesn't matter what type of heart failure you have, you should be on an SGLT2, which is Farxiga or Jardiance. But if you have the systolic heart failure, which is also HFrEF, or heart failure with reduced ejection fraction, then you should be on all these four. So like Entresto, be on a beta blocker, like any of these, and with LOL, the spironolactone, as well as the Farxiga or the Jardiance. Side effects, women women more than men can experience yeast infection, and unfortunately, if you have that side effect with the SGLT2 inhibitors like Farxiga or Jardiance, we might need to stop it. However, urinary tract infections can be prevented. This usually happens because the person is not staying enough hydrated throughout the day, so we just ask them to stay hydrated, more hydrated throughout the day, and we kind of can get away with avoiding that side effect. We talked about already the side effects with the other agents, but I put them here just for to repeat the information. Something that I didn't talk about previously is the MRA side effect. It's a very rare side effect in men, so I did want to mention it. So this is spironolactone. It's usually used with treatment-resistant hypertension, also very commonly used in heart failure. You can have breast tenderness or gynecomastia. So definitely, if you notice that on the spironolactone, something for you to report to your doctor. Dr. Reynolds, do I have time to go over AFib?
Yeah, I think everyone is still engaged. I mean, they're loving it. We haven't lost.
Okay. So AFib is a condition that affects the electricity in your heart. And there are different types of interventions, medications that you can use to try to help with that issue of electricity in your heart. So there are two different approaches. We either can control the heart rate, so how fast your heart is beating, or we can control the rhythm of your heart. So if we want to control the heart rate, which is how fast your heart is beating per minute, we usually use beta blockers for that, or calcium channel blockers, but we shouldn't be using both together. Specifically, you shouldn't be using diltiazem or verapamil at the same time as beta blockers, because otherwise you can have like very serious side effects. Now, if your doctor wants to do heart rhythm control, which sometimes they need to do because they can't do it with the heart rate control, then they might use some of these agents like amiodarone, sotalol, or flecainide. But they have significant side effects with it, so it requires you to see your doctor very often and making sure that they're using this medication safely on you. Your doctor can also try to make a procedure to get you back into the rhythm, and that's called cardioversion. And then in addition to these type of procedures or medication type of therapies to try to control the issue with your electricity in the heart, your doctor might put you on a blood clot prevention, right? Because when your heart is not beating appropriately, it'll cause the blood to pool in the heart in different places, and then it can cause a clot that can then log out and cause you to have a stroke. And so you might need to have a blood clot prevention in addition to medications or procedures that the doctor might have you do. And that is commonly done with Eliquis, which is a Pixaban, which is going generic this year, by the way.
Is it?
And also, yeah, Xarelto, which is going generic this year, which is rivaroxaban. Thank God, because these medications are life-saving. They have a lot of good evidence on them. They're used very widely on these very common conditions, and they're super expensive.
Can I share something also about the Eliquis?
Mm-hmm.
For people that are over like 65 years old, and I'm over that. I do what I call it prophylactically. I have no evidence base to do it. However, if I'm going on a flight, let's say over into Europe or wherever I'm going, long flights, more than 5-6 hours, I will prophylactically take me 10 milligrams initially of Eliquis, starting 2 days before I take off on the plane. I'll take it until I get back for 2 days, and that's it. And guess what? I don't necessarily, I can't say that it really helped what it is, but I got to think about it. To me, it just makes common sense to me. You can get off it at any time, as long as you're on a short period of time. There are no real side effects that I'm aware of, Dr. Cadilla. You may want to correct me if I'm wrong on that, but I take it for myself personally. I'm sure it doesn't work for everybody. I'm not suggesting that for everybody to take them. Just want you to know my anecdotal story by taking Eliquis, and I just love it when I'm out there, like really traveling really deep. You can't get up and walk all down the plane to tell all this other stuff. Just doesn't work. You can't drink enough water, as far as I'm concerned either. So for me, that's Eliquis. Go ahead. I'm sorry.
There's a question on what time can they take. I think it's pitavastatin. The one that starts with a P is pitavastatin. That was a newer one. Pitavastatin you can take at any time of the day. It doesn't have to be at night. Um, and the rosuvastatin you can take at any point, at any time during the day. All right, so in terms of side effects, we've already talked about the side effects of beta blockers and calcium channel blockers. Newer medications here in this slide, amiodarone. So amiodarone can have thyroid toxicity. It can have other toxicity related side effects in other places. It can have lung toxicity. It can have eye toxicity. So very important to stay up to date with those labs that the doctor's doing, making sure you're getting an eye exam every 6 months while you're on the amiodarone to make sure that that medication is not depositing on the eyes and causing the eye damage in the cornea, which is part of the toxicity in the eye. Flecainide can cause side effects of lightheadedness, shortness of breath, and blurry vision, similar with the sotalol too. And the sotalol can also cause what is called the QTC prolongation, which is changes on the heart rhythm too. So just staying up to date. Don't just go AWOL and not follow up with your cardiologist when they want you to make sure that these medications are safe on you still. Side effects with the Eliquis, we talked about bleeding and bruising, but it can also cause low blood cell counts. So making sure you're staying up to date with the labs, not just the physical presentation of these side effects. And as I mentioned, it's an emergency if you have blood on the stool or in the urine.
I guess I would wrap that up.
Yeah. Cholesterol medications was the last slide that I had, and we've talked about these extensively. You've probably heard of the LDL cholesterol, which is the bad cholesterol. Statins is really good at lowering that. Then there are other agents that are used to reduce the LDL cholesterol if you're intolerant to the statins, or the statins are not enough. So those agents are right here. But we also have to start thinking about triglycerides. So this is actually pretty new in the cardiology headspace in the last years. They are talking about a underlying residual risk factor even after we control your LDL with statins and non-statin therapies. If your triglycerides are between 135 to or higher, and you have diabetes and your LDL is looking amazing, your doctor shouldn't stop at just saying, oh, your LDL looks great, that's great. No, but if your triglyceride is still 135 or more, you have a residual risk factor to have a heart attack or a stroke. And cardiologists are paying more attention to those triglycerides too, so they have to make sure that you're optimized on the statin therapy, because statins also can help lower the triglycerides. And if that's not enough, then they might consider using the omega-3 fatty acids for you, to lower those triglycerides and prevent you from having a heart attack or a stroke. Now, there are several agents that are omega-3 fatty acid or fish oil that are prescriptions, most commonly Vascepa and Lovasa. And if you had to pick between two, I would pick Vascepa, because Vascepa has been proven to protect you from having a heart attack or a stroke. The Lovasa did the trial and it failed. It didn't show that it can protect you from having a heart attack or a stroke. Why? Because the Lovasa has a different combination of omega fatty acid, fish oil combination concentrations than the Vasepa. The Vasepa is icosapent ethyl, pure icosapent ethyl, which is a specific type of omega-3 fatty acid. The Lovasa is not. It's a different type of composition. So yeah, it can lower your triglycerides, but it's not to an extent where it's going to protect you from having a heart attack or a stroke. That's the Vasepa. We can also use other agents like the phenofibrates and the derivatives, but these agents, the phenofibrates here in the green, they haven't proven to protect you from having a heart attack or a stroke. The only one in this slide that has that protection is Vasepa. So omega fatty acid, we talked about the prescriptions ones, but can you take the over-the-counter supplements instead of the very expensive prescription one that's available that I said it's called Vasepa? I don't recommend it. If your doctor is recommending that you use fish oil to lower your triglycerides, I would go with the prescription one, especially if you meet the criteria for it. Meaning you have already a history of a heart attack or a stroke, or you have those risk factors and you're about to have it, all right, you have diabetes and you meet the specific criterias for being on the Vasepa, you're already maximized on the statin, I would take that very seriously and use a prescription product. Why? Because the over-the-counter supplements are not regulated by the FDA. They can't make claims to protect you from having a heart attack or a stroke. They can't. So you don't know what you're getting per bottle. So, and then if you switch brands too, every brand has different quality standards. So you don't know what you're getting in different brands. And then within the same brand, if you stick to that brand, you don't know what you're getting from different lot numbers. They can vary and they're not required to report it to the FDA. They're not hold to those standards. So it's not of a good quality product with any proven evidence as the prescription one is, because it's hold to quality standards. But again, all these medications have some benefit, but no benefit is replaceable for physical activity and diet and limiting the salt intake. All these lifestyle adjustments are irreplaceable. They have a benefit that medications will never replace. And making sure that your diet is high in fruit and vegetables, whole grain, healthy proteins, healthy fat and proteins, and making sure that you're at least doing some physical activity, moderate to intense, 30 minutes a day for 5 days a week. Limiting the salt intake to less, and specifically African Americans, because remember, you're more sensitive to this, limiting the salt intake to 1,200 milligrams to 2,000. And I do what I preach. My partner, my husband, is doesn't pay attention to the label at all. And since we've been together, I'm like, look at the back of that label. Look at that vitamin water. How much sugar does it have? How much sodium does it have? He loves to use carbonated water. You know, carbonated water is carbonated because the majority of the time it has sodium in it. So look at the back of the label and making sure that you're staying within those 2,000 milligram limit, which, trust me, you meet immediately. That's all, folks.
All right, guys, I'm all done. Anything else, Pastor Philpott? This has been really great.
Oh, sir, Doc, we're good here.
Okay, so I guess we can go. You can go ahead and do a closing prayer. Let me just close this off. So I can stop sharing the screen, and we're all set. Good.
God, we thank you for what we have heard, what we have learned. Thank you for the persons who have stayed with us, those who had to leave. And we thank you for all of your many, many, many blessings. In Jesus' name, amen.